Hello, everyone. I hope you're doing good. So, Dr. Monica is going to present the case today. I think she is coming. Are you there, Monica? Have you joined? So, I will also make you co-host if you are joined. So, how are you all? I hope you are doing great. We will discuss about the localization of the CNS basically. In per se, we'll talk about the weakness, and this patient is about the neuropathy. So, we'll talk about that fact. And we'll come on to the conclusion about GBS as well. And I am also recording some demonstration videos. So don't worry about those. Uh, I know your exams around the corner. Definitely will like those videos. And if anybody wants to present or want to ask questions, can DM me. All right, I think Monica has joined yet. Wait a second, I'll just ask her. Dr. Monica, have you joined? Please raise the hand or you can just put your message in the chat box. She might be facing some issues of internet. She told me earlier. So just wait for 2 minutes around us. Or somebody else. I have a case. I'll share it on the group. Somebody else can present if she doesn't come in time. Yes, Dr. Monica has joined. So I hope you had no other plans on the Saturday evening. Okay, no problem. She has joined. I've made you host, Dr. Monica. Please start sharing the screen, start sharing the PPT. All right. Okay. Dr. Monica, are you able to share the screen?
Hello, sir. I'm not able to do that. I'm having a difficulty here.
My audio is off, I guess. Okay, my audio is off. Right. Doc- share
Hello,
this.
sir. Is it visible?
Dr. Monica, please share the screen. There is some issue, I guess. Okay, if you want, I will share the PPT. I also have you shared with me. So wait a second. I will share the PPT. You can just read it out. Is it all right?
Okay.
Your voice is not coming, Dr. Monica.
Yes, sir.
Okay. Somebody else would like to volunteer? Just I will share the PPT on the group. You can just open it and you just have to read. We will discuss only. I think she's having some trouble with it.
Hello.
Ah, yes.
Yes,
Manasvi
sir.
is there. Monica is having some issue. Okay, I will share the PPT on the group. Manasvi is ready to present. Okay. So I'll just share the screen. Just a second. I have it with me, I guess. PPT. Okay, I will make you co-host. Manasvi. You can then just turn on your video and audio, and you can also read out. Okay. So it will save our time. Yes. Manasvi, you can unmute yourself.
Sir, am I audible?
Yes, you are audible. Now you are audible. Okay. PPT is not able, you are not able to see, no? Just a second. You all are able to see PPT now?
I'm
Everybody?
able to see, sir.
Okay, great. Let's not waste time. Let's start now. Okay. So I'll be taking the PPTs ahead. Just a second. Okay, let's start. I will not be able to see you all. And please remove this annotation, guys. You're doing. You all can see your annotations. Okay, let's start. PPT is not visible or now it's visible?
It's visible, sir.
Okay. Okay, I have started the annotations like that. Okay, let's start now. Okay,
Okay, sir. A 15-year-old,
sorry. Yeah.
15-year-old male, firstborn to non-consanguineous parents, who's
Mhm.
from Chennai and a Hindu, who's self and reliable.
Mhm. Date of admission
Can
is
you go?
6 and date of examination is also 6.
Presented with fever with productive cough 2 weeks back, with tingling sensation over the feet for 3 days, weakness in both lower limbs for 2 days.
Mhm. Okay. Okay.
A 15-year-old boy was apparently normal 2 weeks back when he suddenly developed high-grade intermittent fever. Child being active in interfebrile period lasted for 3 days. Fever was associated with cough with moderate expectoration, yellow color sputum, non-foul smelling, non-blood tinged, and relieved in 5 days. Not associated with chills and rigors, no pain abdomen, loose stools, vomitings, burning micturition. No history of irritability, headache, neck stiffness, confusion during the illness.
All right.
The boy now complained of tingling sensation over the feet since 4, sir, I'm not able to see.
Okay.
Following which he developed weakness of both the lower limbs since past 2 days, which he noticed yesterday morning as heaviness of both the lower limbs, following which the weakness has been gradually progressive from inability to climb upstairs and downstairs, inability to get up from the floor, repeated falls on attempting to walk with twisting of ankles, slipping of chappals to the present stage of unable to move both the lower limbs. No difficulty in combing hair, in buttoning and unbuttoning the shirt was noticed. No difficulty in rolling over bed, getting up from bed, raising head and holding neck was noticed.
Okay.
No history of reduced sensations or pain over the face of or body. No history of urinary incontinence or detention, syncopal attacks. No involuntary movements were present. No history of difficulty in taking food to mouth, swaying on attempting to walk, giddiness. No history of fatigability or fluctuating weakness. No history of blurring of vision, double vision, impaired sensation of smell, drooling of saliva, deviation of angle of mouth, loss of taste sensation, impaired hearing, difficulty in swallowing, or change in voice. No history of any breathing difficulty. No present history of fever, myalgia, arthralgia, severe pain or discharge, skin lesions, neck pain, irritability, seizures, or altered sensorium. No history of pain abdomen, photosensitivity, or skin rashes. No history of any recent trauma, wound, or consumption of improperly preserved food items. Child is vaccinated for polio and has not received any recent vaccination.
Okay. All right. So I think on the basis of the initial history and the clinical history, let's discuss few things. First of all, fever with productive cough, all right, that indicates that this might be LRTI or maybe URTI, but mostly productive cough will indicate the LRTI, right? Lower respiratory tract infection would be there. Talking about the tingling sensation over the feet. So what does this primarily indicate? Tingling and numbness sensation. Yes, anybody in the chat section? So when you talk about the tingling numbness sensation, basically, which system exactly? So sensory,
Paresthesia.
somatic, exactly. Somatic sensation or sensory system involvement is there. So basically, when we talk about the sensory system, we have two types of symptoms, right? Positive symptoms and negative symptoms. All right. So what are the positive symptoms you guys know of? Yes.
Paresthesias are positive, sir.
Yeah, tingling, all tingling, itching, pricking
Numbness is
sensation.
negative.
Okay, or band-like sensation. These are all positive sensations. So basically, these are all excessive sensation. All right. So whenever you have this type of, and it can be any form, like lightening type of sensation. Many people say that they are getting shooting type of pain or burning or, searing type of pain. Most of the time it is described as pins and needles type of sensation. All right. So it can be anything. And practically we have to just describe it between the positive and negative systems. Okay, so basically, whenever you have this type of complaint like tingling and numbness, so examiner tend to ask about the pathophysiology of these pains because everybody knows that why it is there positive symptom, negative symptoms, so all sensory symptoms. All right. So what is the pathophysiology for the positive symptoms? Yes. Anybody? Yes. I cannot see chat section properly. I don't know why. It has got very zoom. Nerve irritated. Okay, somebody has written nerve irritated, nerve irritated. Increase excitability. Exactly. Okay, so there is an increased excitability at the caused by the ectopic impulses, and typically it occurs in the sensory pathway. All right. And when we talk about the negative symptoms, then there is a it basically is a loss of the sensory function. All right. So it can present in the form of numbness. Okay. So this patient has tingling sensation. That is also called as paresthesia. But when we talk about the negative symptoms, these are only numbness. So what is the mechanism of the numbness now? So obviously positive symptoms were because of the increase of the excitability of the neurons, which is at the ectopic sites, obviously. So here, there is a dysfunction of the afferent nerve fibers. All right. So can anybody tell me like how many nerve fibers are, okay. So we are talking about exactly neural loss will be there. Very good. In the chat section, students are answering. So how many or like how much percentage of the nerve loss should be there to occur, to negative symptoms to occur? Because this is commonly questions asked in your vivas. I'm talking about the postgraduate exams and even MRCP paces. Okay. Yeah, exactly. More than 50%, they say half to 60% is also correct answer. And even if the initial rate is slow, definitely it could not be there. Okay, so we know paresthesia. Paresthesia is what? There is a spontaneous abnormal sensation. All right. So it can present in the form of tingling or like pins and needles type of sensation. And paresthesia is typically non-painful. Second is dysesthesias. Okay, so dysesthesia can be painful. Okay, and this is basically an abnormal sensation. Okay, so basically somebody is touching you and you're getting pain out of that. Okay, that is dysesthesia. Then hyperesthesia. So hyperesthesia is basically increased response to the stimuli, specific stimuli like touch and pressure. Okay, anesthesia, we know complete loss of sensation will be there. Hyperesthesia also we know there is an increased sensitivity to touch or any other stimuli. Then allodynia is there, in which painful stimulation or painful sensation to the non-painful stimuli. All right. So hyperalgesia is the, so what is the difference between hyperesthesia and hyperalgesia? Can you ever tell me? This question also you can commonly get in your exam. Hyperesthesia, or so basically if somebody is touching you and you're getting pain, that is your hyperesthesia. Okay. Somebody has answered in the chat. Very nice. And if somebody is responding so much to the even mild noxious stimuli, that is basically hyperalgesia. Okay. Now coming to the hyperpathia. So what is hyperpathia? Again, there is an increased threshold. Okay, sensory threshold with a delayed perception in this patient. And this is eventually followed by the exaggerated and prolonged response. That is hyperpathia. And finally, sensory ataxia. So we know sensory ataxia is because of the imbalance in the coordination of the sensory tracts basically and the proprioceptive tracts. Okay, that is your dorsal column, isn't it? So that is your sensory ataxia. Okay, so basically what test we do for the sensory ataxia? You guys know this? Yes.
Romberg's test.
Exactly, Romberg's test we do, and there's one more feature of the sensory ataxia. So you know Romberg's, everybody knows now Romberg's, even UG students also know. But what is the differentiating feature? What is one more feature that you should know for the sensory ataxia? So basically, we are positioning our hands and limbs in one position. Okay, so if it is not happening there, broad gait, yeah, that could be there. This is basically indication of the sensory ataxia. Exactly, fall on washing face, that is called as wash basing sign. That can also be seen in sensory ataxia. Inattention, not likely. So,
Not able to enter narrow spaces.
Okay, that can also be one of the feature, but the classical description or classical sign basically, that is pseudoathetosis. Okay, pseudoathetosis. This patient will have involuntary movement of the fingers, hands, and there will be no control basically on that. Okay, so now coming to the localization of the sensory symptom. All right, so we have the sensory symptoms, your tingling, numbness, and all these type of sensory symptoms are there, numbness, etc. So how the sensory pathway goes ahead? So first of all, we have cutaneous receptor. All right, so this cutaneous receptor can detect pain, can detect temperature. Okay, so pain receptor we call nociceptor, temperature receptor we call thermoreceptor. All right, so they have encapsulated terminal. Okay, and they can detect all the mechanical deformation as well, like stretch, pressure. So after cutaneous receptor, we have peripheral nerve fibers. Okay, so peripheral nerve fibers in the form of your nerves. Okay, so this nerve come from the your spinal cord basically. So spinal cord has first of all trunk. Okay, then it comes into the roots, then it comes into the plexus, then it comes to the individual nerves. Okay, so in each of these, you can see the pathology like trunk, then roots, then plexus, then nerves. Okay, depending on the that individual pathway. So that is peripheral nerve fibers. Then sensory pathways basically. So all these peripheral sensation will be taken up to the brain by the two types of fibers, spinothalamic tract and dorsal column. Okay, so what is the function of the spinothalamic tract? You all know that. Exactly. Spinothalamic, pain, temperature. Okay. And the dorsal column is there, which mainly has the function of the proprioception. Okay. Joint sense, fine touch, vibration, proprioception is the function of the dorsal column. Okay. Through the middle lemniscus pathway. We know spinothalamic tract crosses at the level 1 above the vertebrae, and dorsal column crosses at the pyramidal decussation, basically at the level of the middle lemniscus or pyramidal decussation. Okay. So that is about and that's why when we will discuss about the spinal cord lesion, we will talk about that as well. Now, sensory signals are going. So first of all, receptors were there. Then nerves were there. They were entering into via dorsal column, basically. We're entering into the spinal cord into two types of tracts. First one was spinothalamic, that is anterolateral, and the other one was dorsal column. So they are now entering into the spinal cord, and from spinal cord, it will go and ascend into the brain. Basically, where is the sensory relay center? Yes. sensory relay center, basically they will all go to thalamus.
Thalamus.
Exactly. And from thalamus, they will go to the primary sensory cortex. Okay. So if any of this part is affected, you will have the problem. Okay. So what are the possible problems associated with this? So whenever you have cutaneous sensation disorders, that can cause tingling, numbness. Okay. If obviously it can also cause positive and negative symptoms. Then proprioception disorders, you will have balance coordination problem. Then similarly, in these cases, your Romberg's test and all can be positive, right? So even the nerves, first of all, we have cutaneous receptors. If these are affected, you will have pain, sensation, tingling, numbness, or you may have trophic lesions because of you are not able to understand the sensation. All right, that is associated with the receptor. Second is nerve lesions. So nerve lesion can also be associated with the individual nerve. So whatever is the function of that nerve, for example, if the ulnar nerve is affected. So what is the function of the ulnar nerve? It innervates the lateral part of the hand. That is fifth finger and the 1.5 of the fourth finger. All right. So that part will be affected. As an example, I'm telling. So first is receptor is affected, individual function will go down. Nerve is affected, then that nerve's function will go down. So in which conditions nerves will be affected? Neuropathies. Okay. Receptors can be affected in the form of like diabetes. Okay. These nerves can be affected in the neuropathies. So it can be of n number of the causes. We will not discuss right now. And when we go ahead in this discussion, we will discuss about the causes of the neuropathies. Okay. Again, these are described into two parts. Axonal demyelinating. So it's like a big discussion. Okay. So coming ahead, then we have, so as these nerves are entering into the spinal cord via dorsal root. Okay. So this dorsal root can also get affected, causing other symptoms, right? Coming to the spinal cord now. So if spinal cord is affected, if complete cord transaction is there, definitely both the tracts will be affected. That is anterior spinothalamic tract and dorsal column, both will be affected. If only one part of the spinal cord is affected, that is in which syndrome? One half of the spinal cord is affected in which? So whole will be affected in the complete cord transaction, right? And if half of the spinal cord is affected, that is typically seen in which syndrome? Exactly. Many have commented in the chat section. That is typically seen in the Brown-Sequard syndrome. Okay, so in Brown-Sequard syndrome, what happens? Your one side of the spinothalamic tract and same side of the dorsal column tract will be affected. And as I told, that spinothalamic tract was getting crossed. Okay, so here the spinothalamic cord, spinothalamic tract of this side has the sensory function of pain and temperature of the other side. Okay, so there will be contralateral loss of pain and temperature sensation, whereas the dorsal column crosses at the medial lemniscus. That's what we spoke. So definitely dorsal column loss or function of the dorsal column. What are those? Vibration, joint sense, proprioception will be affected on the same side. Ipsilateral. That is called as your Brown-Sequard syndrome. All right. And in certain syndrome where there is only involvement of the posterior column tract. So what will happen in this patient? Joint position, vibration, touch sensation will be lost. So depending on whatever symptoms you have, that's how you localize to the individual tracts, because individual tracts are involved in different type of causes. Okay. So we were talking about the posterior column tracts now. So if posterior column tracts affected, this function will go down, vibration, touch, proprioception and joint position. So what will happen in this case? So in which conditions this can happen? Posterior column affection? Yes.
Vitamin B12 deficiency.
Exactly. So I could combine degeneration of the spinal cord. Okay. Anything else?
Gbs dorsalis.
Gbs dorsalis, very nice. Even multiple sclerosis. So what happens here? So because of the affection of the dorsal column, all right, there is an inflammation and you're not able to bend properly. When you bend, there is a shock-like sensation, okay, in the dorsal column. So whenever you bend the dorsal column like this, so what will happen? There is an electric sensation, electricity-like sensation goes to the head, okay? That typically is called as what sign? You guys know this?
Lermit sign.
That's called as Lermit sign. And Lermit sign is typically seen in multiple sclerosis, can be seen in all the posterior column diseases, all right? So after that, as the signal goes up into the brainstem, okay, so in the brainstem, it can cross at one point. Like, so in brainstem, if it crosses, you will see the cross-sensory deficits because it's crossing in the brainstem. Similarly, this lemniscus and spinothalamic lesions can even cause this contralateral sensory loss. Eventually, it reaches the thalamus level. When it goes to the thalamus, there will be, typically it goes into the ventral posterolateral nucleus of the thalamus. And from there, it goes into the cortex. So depending on if thalamus is involved, you will get hemisensory loss. Okay. And you can also get thalamic pain syndrome, basically, in which there is a severe persistent burning basically pain. Persistent and burning type of pain is there on the other side. What that syndrome is called as? Severe persistent burning on the contralateral side. Yes, you guys know this thalamic pain syndrome. That is Dejerine-Rousseau syndrome. Okay, so we are discussing localization of the sensory pathology. We went on from the receptor, then nerves, then roots, then spinal cord. Then we went up into the brainstem through the tracts. There will be contralateral hemisensory loss. Then coming to the thalamus, there also hemisensory loss will be there. Okay, and there is one more syndrome in the thalamus that is called as thalamic pain syndrome. So in which typically there will be increased sensation of the pain, and severe pain will be there, and persistent burning type of pain will be there. That is called as Dejerine-Rousseau syndrome. Now coming to the cortex. So in cortex, you have your sensory center, basically. Okay, primary sensory cortex. So if parietal lobe lesion is there, definitely contralateral hemisensory deficits and impaired cortical modalities will be there, like 2-point discrimination. So these are all higher cortical functions, right? When we do the systemic examination in sensory system, we have some cortical examination, like stereognosis is there, 2-point discrimination is there. So all these sensory functions will get affected. Okay, so with the history also, some of the times you can get that where is the localization of the sensory symptoms. Okay, and if patient has epilepsy, okay, if patient has epilepsy or if patient has any other psychogenic symptoms, then you can get the idea that this is the symptoms of the cortex. All right, and how do we differentiate this? Basically, that where is the if root? So basically, root involvement has typical type of symptoms. Okay, so when we talk about the root, it has 3 main type of symptoms. So can anybody tell me what is the classic feature of the root involvement? What are the classic 3 features of the root involvement? So we are just into the localization only. I just want to explain it here only so that there is no problem when we go ahead. So 3 classical features will be there. First of all, classically, you will see root pain. So what is root pain? That is a radicular lancinating short duration, okay, shock-like pain in the particularly whichever root is involved. Okay. Second thing, there is a dermatomal distribution. So depending on what dermatome that root of the spinal cord is supplying, that will be involved. Okay. So it is dermatomal and it is myotomal as well. Okay. So suppose suppose C5, C6 is involved and it is supplying biceps. So biceps will be involved. Okay. So depending on whatever muscles it is supplying, whatever part of the skin it is supplying, sensory supply, and it will be mostly a radiating, lancinating, short duration pain. Okay. So that is the classic feature of the root. And what about the plexus? So all the nerves basically are coming from the plexus, right? So root is divided into 2 ramus. You're getting it, or we are going too much detail? You want to go it a little slow? All right. So when root is coming, we have 2 ramus, anterior ramus and posterior ramus. All right. So what is the function of the anterior ramus? So this anterior rami only will form the plexus, and the posterior rami goes and supply the paraspinal muscles. So this is the spine, paraspinal muscle supplied by the posterior ramus, and anterior supplies form the plexus. So if this plexus is getting involved, so plexus has all the nerves, right? So definitely it will be involving the part of the nerve it is supplying. So mostly it is unilateral. Okay, you're getting it? What we are talking, plexus.
Yes, sir.
Diagram, I'm not sure if you can do that. Okay, but I will share the notes. Everything I will share, so don't worry about that. Okay, so it is mostly plexus has a severe type of pain. It is deep-seated severe type of pain, and it is long duration pain, unlike root pain. Okay, so suppose if somebody is coming that always I am feeling this pain, so mostly it's a plexopathy. And somebody's saying I'm having short, sometimes I'm having this type of sensation. It's going and again coming back, but it is very sharp and lancinating type of pain. Then that is a root involvement. So also, if we do EMG, electromyography, okay, that also helps to identify if it's root or plexus. How? With the EMG, that is electromyography, you can check the function of the individual muscle group. So suppose we are taking for the paraspinal muscle, and we know root has been divided into two ramus, anterior ramus, posterior ramus. Posterior ramus is coming to the paraspinal muscles. Anterior ramus is going to the plexus. All right. So if plexus is involved, you will not have paraspinal muscle involvement. But if root is involved, you will have this posterior ramus involvement. All right. So this posterior ramus is basically supplying these paraspinal muscles, and this paraspinal muscles if affected, then that's a root problem. I hope you got it. No problem. I'll share the notes also. Okay. So then coming to the nerve, individual nerve. So in nerve, you can get two type of sensation. So in this patient, you can see what were the, go to the HOPI. So HOPI, if you see, let's ignore the cuff part because it's a neurologic case, which you should not obviously, but otherwise we would go into the respiratory system. That's why. Okay. So here, if you're talking about, can you read it out, Manasvi?
Yes, sir.
Yes.
Boy now complains of tingling sensation of the feet since 2 days, following which he developed weakness of both the lower limbs since the past 2 days, which he noticed yesterday morning as heaviness of both the lower limbs, following which the weakness has been gradually progressive from inability to climb upstairs and downstairs, inability to get up from the floor, repeated falls on attempting to walk with twisting of ankles, slipping of chappals to the present stage of unable to move both the lower limbs.
Exactly. Okay, so it's showing that the proximal muscles are involved, and then distal muscles are gradually getting involved. All right. So how do we say that the proximal muscles are involved?
Unable to get up from the floor.
Exactly. That is the feature, unable to get up from the floor. And what is the classical feature for the distal muscle involvement in the upper limb?
Slip, upper limb, unable to comb.
Yeah, unable to comb or unable to button up button, unable to perform fine activities. Okay. And why do we need this? Why do we need this proximal distal involvement? Why do we need this? Why should we ask this, or like why do we need this? Like what will be the distribution? So basically we are localizing that which part of the nerve is affected. Okay. So as I said that when we talk about the nerve involvement, it can be of two types, right? Axonal and demyelinating. So axonal are mostly distal, and it is also called as length dependent. Why length dependent? So nerve fibers are longer in the legs. Okay. So that's why a length dependent involvement is there. That's why axonal is coming first. And then if you talk about the demyelinating pathologies, where proximal is the first involvement. Okay. Proximal to distal is almost equal in the demyelinating. So that's why in this case, you are getting almost fairly like at the same interval, you're getting involvement. But if you talk about the axonal neuropathies, okay, so axonal are mostly not because of the GBS. Okay, it can be in axonal variant of the GBS, but classically, if you talk about the axonal, it can be paraneoplastic or it can be toxin related. Okay, that's how the axon. So basically, what we are doing over here is we are understanding that what group or like what layer or what type of the nerve involvement is in this patient. Okay, so what are the other things that you see if the axonal and demyelinating changes will be there? Which one has the wasting, muscle wasting will be faster? Axonal or demyelinating? Okay, somebody has posted axonal. Exactly. Why? Because this axon has all the basically mitochondria, all the power sources for the muscles. Okay, that's basically giving supply or power supply to the muscles. And if it's not happening, then that's why it's getting wasted. Okay, unlike demyelinating. All right. And which is the acute one out of two?
Demyelinating.
Yes, demyelinating is acute to subacute. Axonal is chronic. Demyelinating mostly has paresthesia, weakness, and mostly you will get like very few symptoms. Basically, this patient typically don't have much symptoms, but signs will be there. Okay, so what I mean to say is patient will not have major complaints over there. Paresthesia, weakness can be there, but gradually patient doesn't have much of symptoms. And whereas sign wise, if you do examination, there is a vibration and proprioception involvement much more than the axonal. Okay, so I'm just saying over here is that in demyelinating, you can get vibration and proprioception more involvement. And in axonal, you get pain and touch temperature mostly involvement. Pain, temperature, mostly involved. So spinothalamic tract more commonly affected in the axonal, and demyelinating, your vibration and proprioception will be most commonly affected. Okay. Yes. So what are the causes for the axonal and demyelinating? There is also one more, neuronal is also there, okay, in which whole the nerve is basically affected, and as such it has poor prognosis. So what are the causes for the axonal involvement, guys? Yes. So as I said, axonal is mostly because of the toxic metabolic components, HIV, okay, HIV associated Yvonne, you must have heard about that. Okay, HIV associated neuropathy, diabetes mellitus, and Charcot-Marie-Tooth disease. Okay, that is mostly axonal. Coming to the demyelinating causes. So in exam, definitely you are going to get this question. What are the demyelinating causes? So first is, and very important, is GBS. Okay, that is Guillain-Barré syndrome. Then diphtheria. Then chronic CIDP, basically chronic inflammatory demyelinating coronary. Then diabetes can cause both axonal and demyelinating. Okay, and multifocal motor neuropathy, that can also be demyelinating.
Multiple sclerosis.
A multiple sclerosis is demyelinating, but it's not classically neuropathy. Okay, it can cause, it can affect spinal cord, it can affect cortex, basically it can affect anything. Okay, and there are certain medications also which can cause neuropathies. Okay, so what are those medications? Do you know by chance? At least you should know one part. And if somebody asks about the neuronopathy, okay, there Sjogren syndrome is one of the common cause for the neuropathy. Okay, so remember this part as well. Neuronal or neuronal involvement, that axonal, demyelinating, and neuronal involvement is there. So if neuronal involvement is there, it's mostly seen in the Sjogren syndrome. Now talking about the drugs causing neuronopathies. So talking about demyelinating, we have amiodarone is there. The anti-cancer drugs can be there. Even chloroquine, gold is also there. Okay, so these are some of the drugs: amiodarone, chloroquine, gold. These are there. Talking about the axonal, there you will get most amount of the anti-cancers like vincristine, paclitaxel. Okay, even isoniazid is there. So somebody's mentioned isoniazid in the chat box. So isoniazid is mostly linked with the this type of neuronopathies. Okay, so most of the drugs causes axonopathies, axonal neuropathy or axonopathy, and as I mentioned, gold, amiodarone, chloroquine. These are predominantly linked with the demyelinating. Okay. Yes. So when we talk about acute causes of the neuronopathy, suppose a patient comes to you with such a symptoms. So now this patient has symptoms since last 3 days only. That's acute. Okay. So if symptoms are less than 4 weeks or symptoms goes 1 to 3 months, that is subacute. So in acute and subacute, what would be the common causes? First DD for me would be, yes, anybody? Acute inflammatory demyelinating coronary. Okay, AIDP would be the first cause. Second cause, I will give you a clue. Patient has presented with the abdominal pain. There are some rashes on the body, and he's also having proximal muscle now progressing to the distal muscle. Involvement is there. Descending paralysis is now there. Can be ascending also.
GBS.
No. Abdomen pain, why would occur? No, abdomen pain. Exactly, that's acute intermittent porphyria. Very nice. So porphyria is there. So talking about the acute subacute causes, we have AIDP as a first DD. We have porphyria as a second DD. Then vasculitis. Okay. So this vaginal granulomatosis, even PAN. Okay, this type of vasculitis can cause this type of neuronopathy or paraneoplastic features. Okay, so these are all acute. Coming to the chronic, we most commonly we have CIDP. Okay, then multifocal motor neuronopathy. Okay, MMN. MMN is mostly caused by all the autoimmune mechanisms. Then we have diabetic neuropathy. That is also chronic, right? In exams, you all get confused on this. So you can only tell AIDP and CIDP. That's it. You don't tell anything else. So remember, acute, subacute, AIDP, porphyria, vasculitis, all are there. Talking about the chronic, we have CIDP, MMN, diabetic, then metabolic causes. So all of these are there. Okay. Even hereditary neuropathies like see your Charcot-Marie-Tooth disease, etc., can be chronic. Okay. So neuropathies can be of two types: axonal and demyelinating. In axonal, in acute, basically. So now I think we are going into little detail. Just focus on this. So first of all, neuropathy is there. Demyelinating, in which acute is GBS and diphtheria. Subacute is CIDP. Chronic is hereditary. That is demyelinating. I could have written this somewhere. I think, let me just try once. Okay, so let me try. Okay, so neuropathy. Yeah, it's good. Better than nothing, actually. Okay. Yes. So if we have axonal, acute, subacute, and chronic is there. Okay, and similarly here, acute, subacute, chronic is there. Okay, so in axonal, we have M1, that is axonal variant of the GBS. We have AMSAN, that is sensory, and both axonal variant of the GBS. Okay, this is motor variant for it. This is sensory. Then we have porphyria. It goes into the axonal category. Remember, more distal, sorry, more proximal than distal, whereas GBS is more distal. It's a sending paralysis. Coming to the demyelinating, acute, we saw GBS will be there. One more will be there, that is diphtheria. Okay. Then subacute is again CIDP, can be paraproteinemias. Okay. And chronic is hereditary. Okay. So I hope you got this. So it's good. We can write down like this now. Okay. So these are various causes of the polyneuropathy. So I hope you got about the basic idea that how should we approach the cases of the neuropathies. Any doubts still now, guys? Okay, great. So let's go to the second slide. I want to write something actually. Can we get little blank space? Okay, here is little blank space. So depending on the pattern of weakness also, so there are certain typical, okay, I think we can do it only when it is in the full screen. Okay, it's got hang, I guess. Now what's the issues coming? Just a second. You are not able to see the screen? Okay, I'll just stop the screen share and I'll again start. I'll just stop the screen share and I'll again start. Just a second. One second, guys. All right, just give me a second. Once again, I will put it in the OneNote so that I can write down also, so that it will not be a problem. Yes, great. We have it. All right, now it's good. So we were discussing about this part, right? We were discussing about this part. That is, this is negative history. Yeah, we were discussing about the typical patterns of the neuronopathy. Okay, guys, I want you to know there are certain patterns when we talk about the neuronopathies. Okay, so what are those patterns? First is, okay, so the first is symmetrical pattern. Okay, so symmetrical. In symmetrical, we have proximal plus distal. Okay, and sensory plus motor involvement. Okay, so if proximal, distal, sensory, motor involvement all will be there, you should consider GBS CID. Okay. Yes. Okay. Then if you have symmetrical with proximal plus distal involvement, I'm just saying that proximal muscles are also involved, distal muscles are also involved, and plus you only have motor symptoms. Okay, sensory symptoms are not much. Okay, that is again very classic for the GBS. Okay, GBS you will have more motor involvement than the sensory involvement. Okay, that is also can be seen in the GBS, mostly motor symptoms, and also can be seen in the CIDP. Okay, so GBS can have either both of that. Okay, then distal symmetrical, basically motor involvement plus or minus. Okay, so sorry, sensory involvement is plus minus, sensory plus minus, motor is there. So we know now this is typically seen in the axonal type of neuropathies. All right, so these are some of the patterns that I want you to know. So I just don't want to complicate here. But anyways, I will just explain it in next case. All right, this is just our second case. So we might need some buffer period, I guess. Okay, so anyways, I think can we go ahead? Okay, must be. I think let's go ahead.
Yes, sir.
Okay, so you have asked for the negative history over here. So many, just let's go quickly through the negative history. All right. So there is no history of reduced sensation or pain over the face, just to rule out the involvement of the cranial nerves. All right. Then no history of urinary incontinence, retention, syncopal attacks. All right. That's also gives the cortical involvement or even spinal cord involvement can show urinary incontinence. Then
No involuntary movements were present. No history of difficulty in taking food to mouth or swaying on attempting to walk or giddiness. No history of fatigability or fluctuating weakness. No history of blurring of vision, double vision, impaired sensation of smell, drooling of saliva, deviation of angle of mouth, loss of taste sensation, impaired hearing, difficulty in swallowing, or change in voice.
okay, so in this patient, basically, if this is a, let's suppose neuropathy, okay, this is a polyradiculopathy or neuropathy, what features you are expecting in this patient? What should have been there to categorize this patient as a serious case? In severe case, what would have happened? Cranial nervous involvement would have happened, all right? So GBS, if it is a neuropathy, that can involve all the nerves. It's a demyelinating polyneuropathy, right? So gradually it will go and involve all the nerves. Okay, and that's why you can see, yeah, 8, 9, 10, all the respiratory involvement will be there. So all these nerves can be there, gag, reflex, etc. All this can go, and that's why you check for this. Okay, even you can just develop the respiratory muscle paralysis. All right, so that's why we check for these things. Then that's why you ask for the same, no breathing difficulty over here. Okay, then no history of fever, myalgia, arthralgia, of ear pain, discharge, skin lesion, neck pain, irritability, seizures, altered sensorium. Okay, so definitely this is to rule out viral, but this patient already has, right? So presently he doesn't have anything, but 2 weeks earlier he has. Okay, so then no history of pain, abdomen, photosensitivity, skin rashes, just to rule out vasculitis, porphyria. Okay, pain abdomen, you have cut down the porphyria, photosensitivity, skin rashes, you have cut down the vasculitis. No history of any recent trauma, wound, or Consumption of improperly preserved food items. So for what we ask this? Consumption of improperly preserved food items. What should be ruled out? Yes. What are the causes for the descending motor paralysis?
For history of acute gastroenteritis.
No. Actually, it is asked for the botulinism. All right. Somebody has mentioned in the comments. Very nice. It is basically, typically, it is asked for the botulinism. All right. In this patient, you can get ascending paralysis, but just like your patient. Okay. So, what are the DDs for the ascending paralysis? So we know Gbs is one which causes descending paralysis. But what are the ascending paralysis? That means distal is involved first and then goes to the proximal.
Polio.
Sorry, ascending. Yeah, tell me. Sorry. Tell me. Gbs is classically ascending. Gbs is classically ascending. And what are the causes of descending? That's what I'm going to ask. So descending, you can remember by the body. Okay. T is for tetanus. P is for botulinism. Okay. Botulinism. And D is for diphtheria. So these are the DDs for the descending paralysis. And ascending paralysis is most commonly AIDP. That is your GBS. Okay. Yes. And then what are the causes of the most common causes of the GBS? What are the most common causes of the GBS, guys? Okay, Clostridium. Oh, exactly. Campylobacter jejuni. Basically, that is one of the most common cause of the GBS. All right. And it is commonly associated with what variant of the GBS? Do you know this? So basically, GBS can occur after all types of infection. Either it is GI, either it is a respiratory infection, even vaccinations, mostly live vaccinations. Okay, like flu vaccination, even after COVID vaccinations, even if it's dead-killed virus, we have seen after COVID viruses as well. Okay, so in the other variant, we used to give this. Okay, so even in yellow fever vaccine, okay, that's also one live vaccine. Okay, measles. So all these vaccine are basically and one of the common cause for the GBS itself. Okay. So yeah, what I asked was in how many patients of GBS you would see this Campylobacter jejuni. So all infection should occur within 1 to 4 weeks. Okay. So here Campylobacter jejuni infection has occurred. Actually, it is more than 70%. Okay. More than 70%, but it mostly causes motor external neuropathy. Okay, MN. It is most commonly associated with that. Okay, even mycoplasma. Okay, mycoplasma, HIV, CMV. This all can cause GBS. Okay, so that's it. Even like trauma also can cause GBS. All right, sometimes. So post trauma also, what happens? There are certain damaged neurons. No, so these damaged neurons basically will produce autoantibody against it, right? You know the mechanism of the GBS. It's an autoimmune mechanism, all right? So what are the antibodies also that we will discuss in future thing. But in trauma also you can get. So that's how you can explain all the things what you have written over here to the examiner. And he will be very keen to know that why you have written so. And if he doesn't know anything, he will absolutely get offended. But you should have reasoning behind whatever you're talking. Now coming to the past history. So please read.
Past history. No history of similar complaints in the past. No history of any medical disorders.
Okay.
Treatment history. He had taken over-the-counter medication for his fever and cough 2 weeks back, details of which were not known.
Okay. It's all right. So antenatal, postnatal is, I think, not significant over here. Okay. So we can skip this. This is not significant. Developmental is
Developmental.
yeah.
All
This is
domains
also
of
not significant.
development were
This is
achieved
also
at
not
appropriate.
significant, but it is written everything. Okay. Just make sure you write everything because time constant is there. That's why I'm just skipping this part. So this is very well written. Treatment, then antenatal, natal history, developmental history, immunization history, diet history, everything you have to write. Okay.
Family
history.
history,
So
not
why family history
significant.
would be important over here? In which variant of the GBS you can see family involvement? Anybody? Yeah, Wheeler-Fisher basically. Most commonly it has family involvement with the G1Q antibody, but it can be associated with even AM and AMSON can also shows that. Okay. So that's why you can ask that. It's all right.
Personal history, consumes mixed diet, appetite normal, sleep, no change in pattern of sleep, bowel and bladder habits regular, denies any deleterious habits. Socioeconomic status, Kupuswami scale 3.
Okay, that's good. So this is your summary. Please summarize.
Summary, 15-year-old boy of birth order 1, born of non-consanguineous marriage, full-term, non-normal vaginal delivery, belonging to class 3 Kuppuswami scale. All developmental domains achieved appropriate for age and fully immunized, was brought to OPD with complaints of fever and cough 2 weeks back, acute onset, symmetrical, proximal and distal lower limb weakness, progressing to inability to move both the limbs from the past 2 days. No history of sensory autonomic involvement, no similar history in the family, and no other medical conditions. I would like to think of GBS, acute inflammatory demyelinating polyneuropathy subtype.
Yeah, it's actually the clear-cut case. So definitely we will think of the GBS also in this patient. But what are the DDs for this? Okay, if you're suspecting any DDs, obviously you have ruled out so many. But when we talk about the ascending paralysis patient like this, what are the other probabilities you are considering for the ascending paralysis like this? Very nice. Somebody has mentioned that. So hypokalemic periodic paralysis is very common. But see, in this patient, as such, there is no history of like carbohydrate-rich diet. And in hypokalemic periodic paralysis, you will see there is a similar history in the past as well. Even the parents have this type of history in hypokalemic periodic paralysis. All right. So that's why it can be ruled out over here. And that's why she asked that was there any evidence or history of the similar complaint in the past. Okay. So that's how you can rule out the hypokalemia as well. Okay. Coming to the examination part.
Examination. The boy is conscious, cooperative, well-oriented to time-place person. He looks well-nourished. Boy has been brought in a wheelchair and is unable to get up from sitting position. Vitals, pulse rate 76 beats per minute, BP 112, 110 by 70 mmHg, respiratory rate 18 breaths per minute, temperature febrile 98.6 degree Fahrenheit.
Yes.
Head-to-toe examination, pallor, icterus, cyanosis, clubbing were not present, lymphadenopathy not present, edema not present, no neurocutaneous markers or skin rashes.
Okay.
CNS examinations, higher mental functions, conscious, alert, and cooperative. Appearance and behavior of the person is normal. He is oriented to time, place, person. Attention span normal. Language normal. Speech normal. Memory intact. Immediate, recent, remote memory intact. Intelligence normal. Lobar functions normal.
Okay. So overall, higher mental functions are normal.
Normal.
Means there is no cortical involvement as such in this patient. Okay. Then similarly, cranial nerves, I think it's normal only.
Normal.
Okay. So cranial nerves, so it's very well written over here. You can see 1, 2, 3, 4, 6. Okay. Together they have written. So we will discuss detail in a examination part as well about how to check for the each cranial nerves over here. But this is more over case scenario, so we'll stick to that. Okay, so here I can get the cranial nerves are commonly most early moreover normal only in this patient. All right, right. Then let's move to the next part. Yes.
7 to 12 cranial nerves normal.
So every cranial nerve is normal. Okay. So what is one of the most common nerve that is affected in the GBS? Yes, guys.
9.
9 or 7th? 7th is most common. Okay. 7th, then 9th, then 10th and 12th. Okay. So these are the commonest cranial nerves involved in the GBS. And gradually all the cranial nerves eventually can come. Okay. So talking about the motor system now.
Motor system examination. Bulk.
Mhm.
Arm circumference is equal on both sides. Forearm, thigh and calf circumference is equal on both sides.
Okay. Tone is
Tone is normal in both the upper limbs. Hypotonia noted in both flexors and extensors of both lower limbs.
okay. So that's obviously suggests what path, where is the lesion? UMN or LMN?
Element.
Obviously, yeah. Hypotonia, right? Now coming to the power. So obviously
Power is 5 by 5.
upper limb is normal.
Insha.
Upper limb is normal. You're just skipping. But make sure while explaining and while writing, right? Like just like this PPT, everything should be mentioned at the joint, shoulder joint, elbow joint, all the flexion, extension, abduction, adduction. Okay, internal rotation, external rotation. Everything is mentioned so nicely over here. Okay, just make sure you mention like that only in your exams. So moment at the wrist joint, again same thing. Everything is normal over here. Talking about the hip joint, this is important to know. Okay, so power becomes 0, 0
Power is 0.
in all the
Flexion, extension, abduction, adduction, external rotation, internal rotation. Power is 0 by 5.
yes. Similarly, here also you can see
Movement at ankle joint, flexion, extension, power is 0 by 5 in both limbs. At ankle joint, plantar flexion and dorsiflexion also 0 by 5. Toe movements, he is not able to do flexion and extension.
yes. Similarly,
Reflexes, superficial reflexes, corneal conjunctival abdominal and plantar corneal conjunctival abdominal reflexes were present. Plantar reflexes absent on both the sides. Deep tendon reflexes 1 plus on both the sides for biceps, triceps, and supinator reflexes. Knee and ankle jerk, knee reflex and ankle jerk were absent.
okay. Okay. So about the reflexes in the GBS. So how would be reflexes typically in the neuropathy?
Decrease.
Yes. Exactly. Absent reflex. Okay. Diminished reflex will be there. Okay. Very nice. Coming.
Coordination.
Mhm.
Upper limb coordination is normal. Lower limb coordination cannot be elicited. Involuntary movements are not present.
Okay.
Sensory system examination. Coming to pain, temperature, pressure, they were intact on both the sides. Posterior column sensations like fine touch, vibration, proprioception were intact on both the sides.
Yes.
Cortical sensations, tactile localization, 2-point discrimination, stereognosis, graph aesthesia were intact on both the sides.
Okay. So these are all cortical sensation. And that's how you can rule out over here. So sensory symptoms, mostly in GBS, you will not get much of sensory symptoms, sensory signs. Okay. So still you can get sensory signs, but sensory symptoms will not be there. Okay. That's what I meant. But here, their sensory system is intact. All right. Cerebellum is also intact. No?
Cerebellum examination, titubation, nystagmus, scanning speech, dysmetria, dysdiadokinesia, intentional tremor, rebound phenomena, pendular knee jerk absent. No signs of cerebellar dysfunction present.
So you can just write down like that, or you can say normal cerebellar examination. But obviously, if asked, you have to tell what is titubation, nystagmus, which we will discuss when we talk about the examination in detail. No doubt about that.
No signs of meningeal irritation. Gait couldn't be examined. Skull and spine normal.
Yes.
Other system examination, CVS respiratory system per abdomen examination normal.
Okay. Right. So we are coming to the diagnosis only directly now.
Diagnosis, Guillain-Barré syndrome, subtype acute inflammatory demyelinating polyneuropathy, anatomically polyradiculoneuropathy, etiological, immunological, molecular mimicry.
Correct. So let's quickly discuss about the GBS now. First of all, what are the variants of? So we know of AIDP, which is the commonest one. Okay, AIDP is there. Acute motor axonal neuropathy is there. Acute motor sensory axonal neuropathy is there. And your favorite Miller-Fisher syndrome is there. Okay. So what is the classical feature of AIDP, MSAN, MAN and MSAN? So AIDP typically it's acute, obviously, and typically it is not characterized by no early vesting. There is no vesting in these patients. Okay. Talking about the MN, it is mostly motor, okay, axonal. There will be vesting over here, early vesting you can see. And there's a positive GM1 ganglioside antibody, anti-GM1 ganglioside antibody. And it can be associated with the, just like we discussed, Zika and other viral infections as well. Okay, even Campylobacter jejuni as well. Talking about the MSAN, so MSAN is quite severe. Okay, here sensory involvement will be there, sensory axonal involvement will be there, and definitely this is most severe, one of the severe form. The progression can go even lesser than the 7 days in this. Okay, then when we talk about the Miller-Fisher syndrome, so what are the features of Miller-Fisher? Ataxia, ophthalmoplegia, and areflexia. Okay, so my handwriting is not very good, but it's all right. Okay, and what is the antibody for this Miller-Fisher syndrome? What is the antibody for Miller-Fisher syndrome? Yes, exactly, GQ1B. Okay, GQ1B, very nice. Okay, so GQ1B antibody is typically seen in this Miller-Fisher. All right. So typically in GBS patient, weakness is never there. Okay, weakness is never there. So make sure that, okay, weakness mostly occurs because of the corticospinal tract, but make sure, sorry, not GBS, I mean Miller-Fisher. I mean Miller-Fisher syndrome. In Miller-Fisher syndrome, weakness will never be there. Okay, so no involvement of the corticospinal tract will be there. Okay, there are other variants as well. That is bifacial. Okay, even pharyngo, cervico. Okay, cervicobrachial or brachiocrural or just paraparetic variant. Okay, pure ataxic variant. Okay, so there are obviously so many variants for the GBS. So always even just small fiber variant. Okay, so depending on the patient symptom and when we do the confirmatory things for that investigations, then you can get the diagnosis of the patients in this. Okay, so what is the criteria for the GBS? Yes, anybody knows? What criteria we have? We have two criteria. One is Brighton criteria and one is Asbury criteria. Okay, Asbury criteria. So Brighton is little recent one. Okay, Asbury is little old one. Okay, so these are the two criteria. So Brighton on the basis of 3 level it is there. Okay, level 1, 2, 3 it is there. Okay, so one tells about the clinical criteria. Clinical features of the GBS should be there. Second, on the basis of investigation, which we're going to discuss now. And level 3 is exclusion based. Okay. So clinically, you will have bilateral involvement should be there. Okay. And flaccid weakness should be there of the limbs. Obviously, areflexia should be there. Okay, so this should be there. Investigation wise, obviously, your CSF should have that albuminocytological dissociation. Okay, dissociation, that means more proteins than the cells. Okay, more proteins than the cells. Okay, that is about the CSF. So that should be there. Also, Okay. All right. So, and lastly, exclusion criteria. The exclusion criteria, that means obviously there should be no other alternative diagnosis. Okay. No other alternative diagnosis. There are some messages coming in the chat section. What are those? Yes. Those are there, but we're talking about the Brightons. Okay, we are talking about the Brightons. In Brighton, you mostly need CSF. Overall, in investigation, there are so many things. Okay. So when we talk about the investigation, we have CSF. So CSF should have cells less than 50. Okay. And if they are more than 50 cells, you should consider HIV, CMV. Okay. This infection should be ruled out if they can also cause this type of symptoms. Talking about the NCS, nerve conduction studies, here, depending on if it's axonal or demyelinating, you can get different features. But when we talk about the GBS, that is mostly demyelinating. Okay, so mostly GBS, you will have conduction velocity will be reduced. Okay, then duration will be increased because it is demyelination, all right? So myelin function is to help the signal to pass faster. So if there is demyelination, obviously the duration of the signals will increase. Temporal dispersion will occur. Okay, because myelin sheath is not there. So if myelin sheath is not around over here, okay, this is myelin sheath. So signal should go like this. But if myelin sheath is not there, it is broken like this. Okay, it is broken like signals can go here, there. Okay, that's I'm simplifying it for you. So that's how the temporal dispersion you can remember, and latency overall will be prolonged. Okay, so also there's one more, that is F wave. Okay, F waves will be there. F wave abnormality, you can say, that is there. Okay, so this is very typical F wave abnormality for the radiculopathy. Okay, and that is the first feature you can get in the MCV. Okay, that is the first feature you get in the MCV. Okay, now coming to the next part over there. Treatment, last part. Treatment of the GBS. So yes, so what are the possible options? Yes, Manasvi, would you like to add?
Immunoglobulin.
So obviously, first we do ABC, airway breathing circulation. We stabilize the patient. Okay, and depending on the patient's status, if he requires ventilation or not, we just decide that part first. Then after that, we have two options. First, we should check for the autonomic fluctuation. Okay, so autonomic fluctuation is very common in GBS. All right, almost 30 to 40% severe patient can show autonomic fluctuation, and this autonomic fluctuation patients, that means there is either tachycardia, heart rate is either high, either heart rate is very low, either patient has hypertension, or either has hypertension. Okay, so either this is very low. So this can be, if this is there, then keep the patient in the ICU. Also depending on the patient's O2, SpO2, all these levels. Okay, now when we talk about the patient who we are or like monitoring in the ICU or in the wards, what is one thing that you should check to check for the respiratory
Single breath
distress?
count.
Exactly, single breath count. And what should be the normal single breath count?
20 to 30.
Not 20 to 30, but around 20. Okay, around 20 is normal. Okay, around 20 is normal. If it goes less than 20, that is one of the indicator for the intubation, elective intubation in this patient, and that will help you to understand respiratory distress. But more than that, one test is there that is called as 20-30-40 rule. Okay, anybody knows this? So this 20-30-40 rule is mostly done with the by the pulmonologist. You give the reference to the pulmonology people, they will do this PFT on the ventilator machines. So if vital capacity goes less than 20, okay, if this vital capacity goes less than 20, if there is an increase in the inspiratory pressure more than 30 mm, okay, and increase in the expiratory pressure more than 40 mm. Okay, maximum means maximum inspiratory pressure or maximum expiratory pressure is around 30-40 mm. So this is the indicator basically for the intubation. Okay, so 30 is your inspiratory and 40 is expiratory. Emax, Imax, you can remember. So this is the basically indication of the elective intubation. Obviously, we should check for the ABG. ABG will show what? CO2 narcosis or CO2 retention will be there because of the respiratory muscle involvement. All right. So that is one of the indicator for the intubation. Now coming to the very important point, in GBS, is there any role of steroids? Steroids deny, yes or no?
No, sir.
All right. Exactly, because that can aggravate the inflammation and not inflammation, but infections can be co-associated with the infection. And in various studies, they found steroid is not useful. So we don't have to bang our head every time thinking why steroids not useful. So it's in studies, they have not proven that steroid is not going to help in this patient. So we have two options. What are those? So plasmapheresis is there and IVIG is there. Okay, what is the dose of IVIG? 2 grams per
20.
kg over 5 days. Okay. So, like this overall dose is divided into and given for the 5 days. All right. And plasma exchange can also be done in the form of plasmapheresis. That is 250 ml per kg we do. Okay. 250 ml per kg total volume I'm saying. Okay. In over like 3-4 settings, you can remove that much of the plasma. Okay. So that is about the plasmapheresis. So which one is superior according to you? IVIG or plasmapheresis?
VIG, sir.
No. So actually, this question you can get in your vivas. As such, it's not like you don't have any studies, so both are equal. But depending on the patient's overall condition, okay, depending on the patient's overall condition, let's say if it's very bad and you need early treatment in this patient, early recovery, you should go for the plasmapheresis. Okay, because plasmapheresis starts acting faster rather than IVIG. IVIG will take little time to show its action. Mostly, 24 to 36 hours it takes to start showing its action. That is about the IVIG. And what is the one of the contraindication for the IVIG, or like not contraindication, but I would say what is the complication of the IVIG? Anybody knows? Or side effect of the IVIG? It is related with the meningitis. Anybody knows? Aseptic meningitis, as simple as it is. Okay, aseptic meningitis, and it can trigger other infections sometimes. Okay, plasmapheresis as such doesn't have any, but just hemodynamic stability should be there. Okay, hemodynamic stability is required for these patients on the plasmapheresis. Now, coming to the last part. Okay, we also have one disability scoring. Okay, for the GBS patient. So it's okay if you just know the name. Disability staging is there depending on what is patient's current disability. So we have like 0 to, these are categories into that. We don't need to go into detail, but what is that called as? That is called as Hughes. Okay, Hughes. Hughes disability scale is done, is there for the GBS recovery patients. All right. Finally, coming to the prognostic factors and prognosis. So this is the last part of the discussion. Prognosis of GBS case. So overall mortality is 1 to 5% mortality. Okay. Around 30% mortality if respiratory failure has occurred. Around 70% is a recovery over a period of 1 year. So it's a good thing, right? Over 1 year. So basically, the people, professors in your exams, they ask this question very fondly. They want to know that, do you really know in and out of this topic? So they will ask that, suppose you have missed the GBS in this patient, and now he is starting to recover, but he has some disability, then what should you do? So we don't do anything, all right? 70% of the patient will recover on itself. And if this patient does not develop any severe disease, that means he is already getting recovered. Okay. So if recovery, if a complication supposed to happen, it would have happened in 1 to 3 weeks. Okay. It would have happened 1 to 3 weeks. Even you can see various relapse of the GBS or further period. So ideal answer would be, we will monitor the patient. We will ask him for frequent follow. We'll make sure he is not getting any other infections. We'll make sure of his nutrition. Okay. So that would be your ideal. And around 20% of the people can have residual weakness in GBS. Okay. Residual weakness can be there. So overall, poor prognostic factors. So what are poor prognostic factors? Depends on the age. If age is more than 60, if severe motor weakness was there. Okay. And mostly AMSON, as we discussed, no? AMSON is quite severe. You know? So also there is one NCV finding. So that talks about the CMAP. That is mean axonal potential, CMAP. Okay, if CMAP is less than 20% of the baseline, that is also one of the severe or bad prognostic factor. Somebody asked one question. Symptomatically, one patient given IVIG and symptomatic recurrent, should we give again IVIG or not, sir? You can actually see always before IVIG, give plasmapheresis. That's my approach. Okay. And many professors also prefer this one only. But nowadays in all the metros, the more preference is to the IVIG. Okay. So I would say for chronic cases, go for the plasmapheresis. For acute cases, you can go with the IVIG for IVIG. But always remember, once plasmapheresis is done, okay, once suppose means like once you're doing IVIG, giving IVIG, you can't do plasmapheresis again. Okay, we can't do plasmapheresis. Why? Because it will filter all the antibodies. Okay, again, what is given by the IVIG. So that's not helping us. So first, always, if you think that this patient might not get better, we will try plasmapheresis first. So try plasmapheresis, then you have the option of IVIG. Once you have done the IVIG, you don't have option of plasmapheresis, and you can't do anything. So in one of the patient in my ICU was like for 6-7 days we gave him. So that was a standard duration of the treatment. We gave him IVIG, but he's still not recovered. He didn't recover. Obviously, he succumbed because of the VAP. But that is the thing again. Okay, so I would suggest go for the plasmapheresis first. Then you can just shift towards your approach to the IVIG because you have any other options. And when patient is coming after 6 weeks, make sure if it is CIDP or not. Then if it is CIDP, then you know what is the treatment. All right. In CIDP, any day we give only steroids, isn't it? Rarely you can do plasmapheresis, but mostly it's a steroids only. Okay. So that's all about this interesting case, guys. I hope you liked. Okay. Any doubt? Any doubts? So that later approach actually helped us where I was writing, I think. We will try to do like that only in upcoming discussions.
Sir, after the onset of symptoms, what is the maximum duration till we can give IVIG?
So there is no defined duration actually. Okay. There is no defined duration, depends on the severity of the patient. If patient is severe enough, then we can give.
Even after 1 week to 10 days, can we give IVIG?
Yeah. So depends on the symptoms of obviously if 4-5 almost like 2 weeks have 2 to 3 weeks have occurred since the symptoms started, then IVIG would not help much. But in any books, it is not said that it is contraindicated. So always give the patient the benefit of medicines rather than giving nothing. Giving something is always better. That's what my professor used to say. Okay.
Thank you, sir.
Yes. So if you guys want, shall I explain the sensory somatic symptoms, or you can read the notes? Anyway, it's not that difficult. I will share 2-3 charts. You can read that and you will get the idea. Okay. So I was just in assumption that you didn't understood that well, but I hope you did. So that's okay. Okay. All right, guys, then. Thank you for joining in. On Monday, try to present one abdomen case. So my approach is before January, we will try to cover most of the cases so that the students who are exam going will have the little of benefit on they might have confidence. Thank you. Thank you, Jasmine. Thank you, Azim. Thank you. Okay, so I hope you enjoyed the class. So please on the Monday, if somebody has a gastro case, gastro is not very common. That's kept, but very unlikely. Can anybody present SLE case? SLE is very common for MD finals. It's kept. Even rheumatoid arthritis. In my finals, I had angstpon. Can you imagine seronegative arthritis for my finals? So, anyways, it doesn't matter much. It's all about the approach. They ask about the approach, and that's why 30% of the discussion, or like 30 to 40% of the discussion time in the initial period, I keep only for the approaches. So just after today's discussion, if you go and read the Harrison about the numbness and tingling sensation, that part, I am 100% sure that you will be very much sure that like everything we have covered from that, even with the percentage, because I'm coming prepared for your discussions. So you can revise that to the Harrison, or I will share the notes also. No problem. Okay. So anyways, try to present either gastro case or rheumat case. Anybody, please message me if interested. I will give you a case. Okay. I have very like many cases written. Even this case was mine only. So you can message me just if you want to present. I will give you a case, and just to break the ice, you will get that confident about how to present the case, how to approach that. Most patient of the GBS seen after GIT infection. Yes, Campylobacter jejuni is the most common, obviously. But remember, trigger is always there. Even almost in 50 to 70% of the patient, trigger is there. And trigger can be anything: GBS, respiratory infection, vaccines, as we discussed, viral infection, dengue, malaria, anything. Okay. So done. That's it, guys. Good night.
Thank you, sir.
Yeah, enjoy your Sunday. Very well presented, honestly. At the last
Thank you,
night.
sir.
Thank you so much.
Thank you, sir.
And
My
Monica,
pleasure.
it's no problem. Monica couldn't connect, but you could present in the next session. Okay, you can present in the next session. Okay, guys. Bye bye. Good night. Enjoy the Sunday.